Okay, folks, let's get started. My name is Asha Payne. I am one of the pediatric emergency medicine attendings here at Children's National in DC. I'm going to talk to you guys about essentially ALS topics with respect to pediatrics. Unfortunately, my mobile clicker isn't working, so I will be stuck behind the podium. But please feel free to ask any questions. Just raise your hand, even just shout it out. I'd like this to be as interactive as possible, even though this is a large room. Okay. So essentially, we're going to go through a bunch of cases. We're going to talk about respiratory issues. We're also going to talk about cardiovascular issues. We'll also talk about some altered mental status. Again, all of this in the setting of pediatrics. Again, please feel free to ask any questions. I don't have anything to disclose with respect to this talk. So we'll start with the pediatric assessment triangle, some basic BLS stuff. In terms of the pediatric assessment triangle, it's the thing that you can get from the door of the house or the door of the room, a quick assessment of the child just to see what's going on. It allows us to essentially assess the child without having any equipment or numbers or vitals, just to be able to get a differentiation between sick and not sick. And then it allows us to be able to determine different categories of illness. It also helps us to determine whether our interventions need to be more urgent or less urgent. With respect to the categories of illness, there are about 4 general categories that we're sort of thinking of with respect to the pediatric assessment triangle. Is it respiratory? Is it a perfusion issue? Is it a CNS issue? Is it a metabolic issue? In terms of the appearance part of the pediatric assessment triangle, tickles is the mnemonic that we can use to remember the things that comprise the appearance aspect. What's normal in terms of tone? A kid that moves around, that's active. Abnormal is a child who's floppy unless it is their baseline. You're always looking for interactivity. How interactive is the child with the parents or other providers or other caregivers at the home? A child that's not reaching for anything is just sort of sitting there calm, and maybe too calm is always a little bit worrisome. You want a child to be consolable. That's normal for a child to be fussy but consolable by one of their parents or family members. Children that are not consolable by their care provider is always a worrisome thing. Similarly, if the child is not looking at their care providers or not looking at anything, that's worrisome. Children who are sort of just gazing off into space, you start to worry about some CNS or metabolic issues. Again, this can be a little bit difficult in the context of children who have a developmental delay because some of their baseline may appear to be abnormal with respect to other children. The other thing is their speech and their cry. You want, again, a nice strong cry. You want appropriate speech for their developmental age. And then a child who's not crying, not talking, again, if it's not their normal baseline, is worrisome. One way that I always try and assess the appearance of the child is just to ask the family, is this what the child is normally like when they are their healthiest? Because that way you can get an understanding of, for those kids who might be on a trach and a vent or who might have a developmental delay, that normally they sort of smile sometimes or normally they don't. So you can be able to gauge whether or not sick versus not sick in terms of your mind. With respect to work of breathing in the pediatric assessment triangle, nasal flaring is worrisome. A child that is breathing out and their nostrils widening, that's worrisome. You can have some nasal flaring during inspiration for children, and that can be normal. It's not consistent, and most kids don't do it all the time. But whenever the child is breathing out and there's nasal flaring, that's a worrisome sign. Retractions are always worrisome. Again, some kids retract all the time, but that's a very small number of children. You can see retractions above the sternum, above the clavicle, between the ribs, or what I call belly breathing. Basically, the belly is just sticking out with each and every breath, which is just a way for the child to use more muscles, accessory muscles, to help them breathe. Head bobbing, always a worrisome sign. Basically, the child is trying to draw in their breath, and their head is getting pulled with that as well. Grunting, always a worrisome sign. That child is really trying to keep their lungs open from whatever process is going on in the lung. With respect to sort of these 4 things, I would say the things that usually grab my attention the most would be the head bobbing and the grunting. Those are the 2 things that are really going to sort of raise the hairs on the back of your neck. Yes, nasal flaring is not normal, and retractions are not normal, but in terms of the things you see most often in abnormal work of breathing for children would be retractions and potentially the nasal flaring. Once they get to the head bobbing and grunting, you know something is definitely amiss. In terms of abnormal sounds with respect to work of breathing, snoring can be abnormal. Again, it depends on the child's baseline. If you hear audible wheezing or stridor, again, those are abnormal. If the child is tripoding, basically sitting and sort of leaning forward, trying to keep their head and neck very still, that's a worrisome concept. You can see that sometimes in the rare case of epiglottitis or in a kid who has a foreign body in the airway. Sometimes they will sit so still and they will just lean a little bit forward and not want to move their head or neck because they're doing their absolute best to keep their work of breathing focused on breathing. In terms of rate, the other thing to think about in terms of work of breathing, you want to count the respiratory rate for at least 30 seconds. A lot of people will count for 10 seconds or 15 seconds and just do the appropriate math. I really encourage people to count for at least 30 seconds because you'll be surprised at how much the numbers will actually change over the course of the minute. I personally will actually pull out my phone, put on my timer, and count for a minute just to be very clear what the child's respiratory rate is doing. The other thing with counting for at least 30 seconds is you get a really good assessment of the child's respiratory effort and drive. You get to see if there's changes in the retractions. Does the child retract with every breath, or is it just some? Is the child nasal flaring all the time, or is it just sometime? Is that head movement actually head bobbing, or is it just the kid being fussy? So really taking a little bit of time just to assess the work of breathing in terms of the respiratory rate can be helpful in terms of your assessment and management down the line. I know the pediatric assessment triangle does not require any equipment, but for completeness sake, let's go over the lung exam, which is completely one of probably the more difficult things to do in children, simply because between the fussy, the crying, trying to listen maybe through the onesie, mom's got the kid all wrapped up, it can be a complete mess. And then add all of the upper airway congestion that can completely occlude your exam, things can get very hairy. But that being said, stridor is a high-pitched sound that is heard during inspiration. Stridor is reflective of upper airway dysfunction, so essentially from the clavicles upward, there's something going on. It need not only be in the area of the larynx, but it also can be a little bit in the sort of back of the pharynx and adenoids as well, but it's essentially an upper airway dysfunction. Crackles and rails, sort of like the bubble wrap sound, sort of popping and cracking. Basically, there's fluid in the lung, and the child, as they're breathing in, that lung is opening up, and you're hearing a little bit of wet popping. You hear that sound in bronchiolitis, but you can also hear it in pulmonary edema. I will say it's a little harder to hear pulmonary edema in infants. You have to be a little bit older to be able to focus on that part of the exam, but because infants will often get their livers a little bit large before they actually wet their lungs, but that's a whole other story. Yes. You can also hear it in pneumonia as well. Wheezes are the sort of continuous musical sound that's associated with asthma. It need not be through the entire phase of inspiration or expiration. It can be towards the late end of expiration, but then it also can be during both. In terms of bronchi, it's just sort of the coarse, low-pitched, sort of non-musical sound that you might hear in cystic fibrosis. And then again, on top of that is what I just sort of termed myself as just coarse breath sounds, which can completely occlude your ability to appreciate any one of those. Meaning those kids with so much nasal congestion, boogers, everything and everywhere, and a combination of crackles, rails, and stridor, you can't appreciate anything. So sometimes the nasal exam completely occludes your ability to be able to hear wheezes and crackles. In those situations, you definitely want to suction as much as possible because that will give you some clues in terms of your exam. One thing I noticed when I was preparing for this talk is everybody has different designations about what is appropriate for age. APLS has their own guidelines in terms of respiratory rate. PALS has their own guidelines in terms of appropriate respiratory rate. I'm sure every jurisdiction where I to ask has their own definition of abnormal and normal respiratory rates based on age. And so this paper is published 2011 in Lancet, and basically they looked at APLS, PALS, and one of the international algorithms with respect to pediatrics. And they just basically tried to come up with age-adjusted norms to be able to give you your first and your 99th percentile. And hopefully most of the jurisdictions sort of fall between those numbers. Sum total is that babies breathe faster than all the rest of us. And the older you get, the slower you breathe. The same goes for circulation. Again, everyone uses their own designations for what they're calling tachycardic versus not. The same team published in Lancet in 2011. Again, they tried to normalize basically the first through the 99th percentile in terms of what's the normal heart rate for children, and this is the graph that they came up with. Essentially, you can get a 1 or 2 month old taking up into the 180s, and that technically be normal. Most people would sort of have their cutoff a little closer down to the 160s, but I have seen kids in the low 200s who are fussy crying and getting albuterol, and that be completely normal. So once they calm down, get a little bit of fluid, they get off that albuterol and that heart rate comes down nicely. I have not seen anybody in the 220s or 240s, at least infant-wise, who were not then diagnosed with SVT. Once you start getting in the 220s for the older kids, all bets are off because that's very much abnormal. In terms of blood pressure, they didn't do this, the same article didn't do the same thing for blood pressure, but there are plenty of reference guidelines out there. Harriet Lane has one, I believe PALS has another with respect to what's an age-appropriate blood pressure. From a quick and dirty way to calculate it in your head, the lower limit or the 5th percentile of a normal blood pressure is 70 plus 2 times the age in years, whereas the median or the 50th percentile is 90 plus 2 times the age in years. But again, you should refer to whatever card or designation is appropriate for your jurisdiction. Cap refill time is 2 seconds or less is considered normal, but that cannot necessarily be accurate in infants or when people are cold. Does anyone know where the concept of cap refill came from? Okay, do you know who came up with the concept though? Okay, so I tried to find the exact story last night, but I couldn't find the exact story. But the sum total was actually this nurse in like the 1800s just sort of went around and started pressing everyone's finger, and the people who appeared more normal had a cap refill of about 2 seconds or so, and then she just said that that was normal. So there's never been like a scientific study to determine whether or not 2 seconds is appropriate. It's just what someone did a long time ago, and we're just sticking to it. I put this slide in here because I was asking some of my colleagues who do EMS work on the side as their sort of other jobs. And I said, well, you know, I'm talking to these ALS and BLS providers, like, what do they want to know? I'm sure they're comfortable with kids, like, you know, I feel like I'm just going to be telling them stuff that they already know, like, what should I add to this? And some of my colleagues said, well, you know, not everybody has children, and not everybody is comfortable with children, and not everybody spends much time with children. And quite frankly, some people are absolutely scared when they see a potentially sick kid. So just give them some basic tips on what to do, like what you would do and how you would feel in the presence of a sick kid. So the first thing is to take the first few seconds just to take a glance, take your own blood pressure, and take a second. One of the mentors I have who left my institution not too long ago, she told me, she said, never run to the code room, because never run to the code room, because those 2 or 3 seconds that you can think you're actually saving, you're just getting yourself all worked up and you're getting all excited. Just take 2 seconds, stand back, watch the chaos, because it could be chaos. Let that sort of play out for a little bit. Meanwhile, you're assessing the child. Also, stand back as much as possible. Strangers sort of running up and trying to do something to a sick or maybe unsick child can be very frightening to children. And then approach them slowly. When I'm in the ER, usually I will sort of stand on one side of the room, chit-chat with the parents, and slowly make my way a little bit closer, and eventually end up sitting on the bed, eventually end up sitting on the child. This is not the same thing as when you guys are out in the field and you just scoop and run, or there's a bunch of other things going on. But to the best of your ability and the best that the situation will allow, approach slowly, because sometimes you'll get a little bit more response from the child that way. Again, ask the parents. When, you know, little Johnny is at his healthiest, what is he like? Especially for the developmentally delayed kids or autistic kids, because then you can get a better understanding of what your pediatric assessment triangle needs to change. And then also asking about their tone or their cry. I tell, especially like my medical students and residents, get on their level if you can. If you can sit on the bed with them and you're about eye level, that's better. Make sure you soften your tone of voice, because sometimes as adults, our voices can be very jarring to infants and babies, and sometimes kids as well. So if we just take a few minutes just to lower the tone of our voice, speak a little bit softer, speak a little bit gentler, you might see some better results. And then make sure you reassess children very quickly, because things can actually change. The Pediatric Assessment Triangle also helps us with categories of illness. This paper was published in 2010, I believe that's what it says, and basically just categorizes if you're completely normal for your worker breathing, circulation, appearance, you're probably fine. And then it goes basically to detail out each type of abnormality and what your differential diagnosis or broad category of different differential diagnosis can be. So a little humor to start. Gets you me every time. Grab a piece of paper, because we will be taking a quiz during this talk. The answers will be presented at the end of each case, and the answers will be during each case as well. So your first call of the evening is you get a 6-month-old female with multiple episodes of vomiting and diarrhea in the last couple hours. You get to the house, and this is what the kid looks like. So in terms of your pediatric assessment triangle, kid is slow to arouse, not retracting, sounds are fine, skin color is pale, cap refill is pale. Some additional history, was a full-term baby, vaginal delivery, no fever or URI symptoms, has all of its shots, no drugs, and not taking any medicines. So initial assessment is as follows: a heart rate of 185, blood pressure is 80 over Pulse, respiratory rate of 40 and is afebrile. The airway is open and maintainable, lungs are clear, ventilating well, cap refill is of about 4 seconds, is alert to voice, and no signs of external trauma. What do you think are the vital signs? Don't like them. I don't like them either. What don't you like? Compensating for something. So that heart rate of 185, that's abnormal. Respiratory rate, this is actually the 50th percentile. That's actually normal for an infant. Sometimes they breathe in the 30s, but this is, the 45 itself, for me, is not necessarily worrisome. 6 months old. Exactly. So what's on your differential? Compensating for something. What are we compensating for? Or what do we think is going on? Lost fluids. Anything else? I heard a whisper. Medications, maybe. Good thought. Question number 1. Given the patient presented above, which of the following most closely resembles your differential diagnosis? Is it dehydration and shock, respiratory distress and dehydration, respiratory distress and shock? Again, the answers will be presented at the end. What are the 3 stages of shock? Compensated, uncompensated, or irreversible, compensated, hyperdynamic, or hypodynamic, reversible, compensated, or hyperdynamic, intravascular, extravascular, and interstitial. In terms of shock physiology, what is the thing that children do first? This is different than adults. Do they increase their blood pressure? Do they decrease their blood pressure? Do they increase their heart rate? Or do they decrease their cap refill? With respect to shock, irrespective of the cause, or most of the causes we'll say, what is the most important intervention? Is it fluids? Is it dopamine? Is it oxygen? So essentially this kid is in decompensated shock, likely from hypovolemia from gastroenteritis. In terms of shock physiology, basically what happens is the sum total is that there's inadequate perfusion to the tissues for whatever reason, whether it's loss of fluid or the fluid is in the wrong spot. The tissues themselves do not get enough fluid and nutrients. That really results in decreased oxygen delivery to the tissues. Then that means that those tissues, even though they're undergoing their cellular cycles, have not met their metabolic demands have not been met, leading to metabolic acidosis. And so really the concept behind shock is that the tissues themselves are not getting enough perfusion. There are several different types of shock. Hypovolemic shock, meaning that the tank isn't full, they've lost their ability to push fluid around for whatever reason, or they've lost the fluid that they need to push around. Distributive shock, most of the fluid is there, it's just in the wrong spot. You have a lot of capillary leak like in sepsis. The fluid may be in the third space in the tissues, but it's not actually intravascular. With cardiogenic shock, the heart isn't pumping well, so you may have enough fluid on board, but the pump itself is not working well. Obstructive shock means that the fluid can't get to where it needs to be for some reason. Is there a reason that there's a blockage from the blood leaving the heart? Is there a blockage somewhere downstream that the blood can't get to the tissue? And then dissociative shock basically refers to uncoupling of the cellular processes that basically allows that the cells do not appreciate the fluid that is given to them. Your three stages of shock are compensated, uncompensated, and irreversible. Normal vital organ function is maintained. Basically, you have a normal mental status in compensated shock. Your blood pressure is normal, maybe a little bit increased. The thing that you will notice here for compensated shock is that babies and young children will increase their heart rate, sometimes quite dramatically. When you start falling into uncompensated shock, you're getting less perfusion to the tissues. You're starting to lose your level of consciousness. Again, your brain being one of the major tissues that require fluids and oxygen. Once you start losing that, you start losing your mental status. You get hypotension and delayed cap refill, and then you maybe fall into irreversible shock. In terms of management, airway and breathing always important. Provide oxygen as tolerated. Support their ventilation. Avoid agitation, which basically means that you're trying to decrease their work of breathing, work of effort, to decrease the amount of supply that the tissues themselves need. Obtain IV access en route. Fluid, 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 especially for hypovolemic shock and distributive shock are your main key interventions. 20 per kilo of normal saline or lactated ringers, whichever you have is preferred. 60 per kilo or 100 per kilo is not unheard of in patients with septic shock. I hear, because in sepsis it's a distributive shock, so meaning that all the fluid that you have is not in the actual vessels themselves. You start to leak and those kids start to really swell, and basically all that fluid is not in the arteries and veins, it's more in the tissues, which is not actually helpful. Even though one might think, oh, it's there, it should be fine, it's actually not helpful. You actually need it to be perfusing through the arteries and veins into the tissues. In terms of your vasopressor support, dopamine, norepi or epi, depending on the clinical condition of the child, and I think every jurisdiction probably has their own preference in terms of which one you start with, as well as clinical preference may also be relevant here. And then medical control is always important. So back to our questions. The patient described that we talked about above. The differential really should include dehydration and shock. Your three stages of shock are compensated, uncompensated, and irreversible. Children first begin to compensate in shock physiology by increasing their heart rate. And the most important with respect to shock, fluids, fluids, fluids. Okay, so you pick up the kid, give him 20 per kilo bolus. This is a really long transit time, stuck in traffic, long distance, whichever the case may be. Heart rate comes down a little bit. The first one was 185. Blood pressure is a little bit better. Respiratory rate comes down a little bit, and the patient is afebrile. Now, you lose your IV. You don't have any more IV supplies because someone forgot to put the bag on the truck. What do you do now? Awesome. Love it. IO. If you can't get an IV or it's taken too long to put in an IV and you really need access, or in the event of arrest, or in the event of shock, an IO will be a nice option for you. You can actually get labs from an IO. The hemoglobin, pH, PCO2 bicarb, and the BMP, with the exception of the potassium, glucose, are reliable labs actually to draw off of an IO. The white count, potassium, AST, ALT, and ICAL are not as relevant. And I would say even though you can get labs off of the IO, most of my clinical experience, most of my clinical experiences, usually if folks are going to get labs, they're going to get them first before they infuse any medicines or any fluids. So when you place the IO, you get some fluid back. Some people will take that and use that. But if not, then usually folks will just use it just to infuse, because that's usually more important at the time. You can use your co-drugs and paralytics through your IO. But unfortunately, adenosine is found not to be as accurate in children, and that may be because of the site where most times IOs are placed in children. Contraindications for an IO is a fractured bone or major vascular damage in that extremity. Cellulitis, burns, and osteo are relative contraindications. In terms of the sites in which children are approved for IO, the proximal tibia, distal tibia, and distal femur. I would say most people usually go for the proximal tibia first, and then maybe distal tibia and distal femur sort of second to that. Distal femur, essentially, you want to go sort of midline to the kneecap and go above the kneecap. I think each and every device and or gun has their own approval for sites or not. But I would say pretty universally these three are what people frequently use. And I think in terms of what's easiest, and maybe just because I've rehearsed the proximal tibia the most, that's an easier landmark to find. Essentially you find the tibial tuberosity and go a little bit medial. You keep your hand out of the way, not behind the calf. You want to move it down a little bit, even though the thought is to let me just drill it right through where my hand is. Move your hand down a little bit, get a little bit medial, and make sure you get the flat part of the bone and either screw or use your gun. In terms of placement technique, most of us are familiar. A little lidocaine to the skin if you can, but if not, then you just have to go with what you got. Find your landmarks, insert your needle, whichever mechanism, whether it be hand screw or whatever gun device you have. Confirm your placement. It does not always have to draw for it to be a good IO. Some do, some do not. And then lidocaine infusion for pain can actually be quite helpful. The distension of the bone is actually what's quite painful, so pushing the fluid through that bone and that cortex can be very can cause a lot of discomfort. And so a little lidocaine can be nice for the patient. That being said, lidocaine does burn, and having put an IO in a 6-month-old the other day, did fine with the IO part, but when I did the lidocaine part, burnt, poor thing cried, but then calmed down. But know that lidocaine part is going to burn a little bit. But the long term, it's actually helpful. And then secure with whatever dressings or holder is provided. Take-home points with respect to shock. If there's a lot of fluid loss, consider hypovolemic shock. You want to give fluids and then place your IO as needed. Any questions so far? You can still do 20, otherwise healthy neonates, yes, you can still do 20. I mean, it may just be a couple, one or two saline flushes that you use, but yes, you can still do 20. No, just the full year, just the full year. You get a call about a 2-year-old not responsive. When you get to the scene, I'll show you why there's no picture in a second. The kid is unresponsive, kid not breathing in terms of being very labored, but is taking slow, deep breaths. The cap refill is pretty brisk though. In terms of the history, you're assessing the history on scene. Some URI symptoms that started earlier in the day, not quite active during the course of the day, and now can't get up from his nap. No allergies, shots up to date, otherwise healthy kid. Vitals, temp of 104, heart rate of 180, respiratory rate of 20, blood pressure is 126, 97% on room air. Not responsive, but and also not arousable. Airways patent, a little bit dry in the mouth, but is protecting the airway. Lungs are clear. Cap refill is brisk, is unresponsive, and then no signs of trauma. So what's on your differential? No meds. No meds, otherwise healthy child. Will move a little bit, but not consistently, with a little bit of pain, but not consistently. Pupils are reactive. Yes. Yes, that one I'm sure about. I'm sorry? You don't have that information yet. Your machine is getting turned on. Okay. I'm sorry? They're nervous. Mom's a little bit hysterical in the corner, and dad doesn't know what's going on. It's like, it's dad. I'm sorry? No rash. Fever was just today. Had been having some cough, cold, runny nose symptoms a couple days, but nothing impressive. No recent seizure activity, though. So in terms of your mnemonic to help you remember altered level of consciousness in children, is it HELP? As in, like, I just really have no idea what's going on, let me call for help. Is it vitamins? Is it AVPU and GCS? Is it the 5 H's and the 5 T's? Which of the following do not contribute to maintaining a normal level of consciousness? Is it a relatively normal blood pressure, temperature, appropriate blood flow to the brain, appropriate nutrients to the brain, all of the above, or none of the above? Appropriate nutrients to the brain, appropriate blood flow to the brain, relatively normal body temperature. All of the above or none of the above? Which of the following is not helpful in identifying causes of altered mental status? History, environment, respiratory pattern, or time of day? So altered mental status basically is an awareness of oneself in the environment. To have an intact level of consciousness, you need several things. You need the appropriate energy production, which is glucose for the brain. So hypoglycemics have altered mental status. You also need oxygen. You need adequate blood flow and perfusion to the brain. Again, if you're hypotensive or in decompensated shock, you have altered mental status. Your body temperature needs to be relatively normal. It need not be 98.6, but it needs to be within a relatively normal range. And you need to have an absence of metabolic wastes and toxins, meaning that your PCO2 can't be 120 and expect to be completely appropriate and perfect in your environment, as well as other things like elevated ammonia levels can also cause altered mental status. In terms of assessing mental status, AVPU is the quick and dirty one. I actually prefer that. GCS, you have to do a little bit more calculation and often have to refer to a chart. I know I do. I just sort of look at a chart on the wall. Some people start with AVPU and then move to the GCS if the child is not perfectly alert. In terms of your differential diagnosis of ways to remember, vitamins is a nice way to remember. Vascular stroke, infection, trauma, autoimmune vasculitis, metabolic, ingestion, neoplastic, and seizure is one way to do it. One other way we do it in pediatrics is AEIOU tips. So alcohol and abuse, again, abuse being a very relevant one that is not always on the minds of all providers at the time. So a kid who is 3 and who's altered at the house, it could be a very clear case of non-accidental trauma, especially in the absence of obvious seizure activity, even in the absence of bruises. Electrolytes, so low sugar or DKA, encephalopathy, infection, whether it be meningitis, encephalitis, or an abscess, overdose of some sort, elevated uremic, patients with high elevated BUN can also have altered mental status. Your various head traumas, again, non-accidental trauma being a cause. Insulin, intussusception. Everybody familiar with intussusception? This can be the very classic mimicker of seizure activity and altered mental status. You can have kids who, in the appropriate 2-3 age range, will go through periods of being fussy and then fine, fussy, cranky, angry, fine, being sleepy, not arousable, and then be completely alert. Again, sleepy, not arousable, then be completely alert, and it can very easily be intussusception. Even with a soft belly, non-surgical abdomen, it can be intussusception. It can be psychogenic. They can fake it. Teenagers do fake it. They can. Shock, stroke, seizure, postictal state, or in the kids with a VP shunt, if their shunt pressures are going up and their shunt is blocked, they can also have altered mental status. Some of the common ones in pediatrics: injury, infection, ingestion, being postictal, or having an increased ICP are some more common ones we see. So, as you sort of quickly assessed, then you start to see this. Oh, man. Okay. So what are your thoughts now? So kids having a seizure now for certain. Could be postictal from the one prior for certain. Could be, again, status is another option. So this is your assessment while the kid is seizing. So your diagnosis, some type of seizure activity and or postictal state, plus or minus meningitis, abscess, trauma, et cetera, but the one you can definitely hang your hat on is seizure activity. What are the 2 general categories of seizures? Generalized and febrile, febrile and non-febrile, generalized and partial, non-febrile and partial. What is a common complication of the drugs used to treat seizures? Respiratory depression and apnea, hypertension, tachycardia and hypotension, and asystole. So seizures, basically it's a excessive abnormal firing of the neurons in the brain for some reason. You have 2 general categories, general and partial. General means that it's the entire brain. You have loss of consciousness, and motor and sensory changes. Partial means it's one hemisphere of the brain. Often those kids also have altered consciousness, but not necessarily. But that would require a neurologist diagnosis in terms of complex partial seizures where the child is still awake and alert and talking and sort of shaking, one hand or one leg. So febrile seizures are a subcategory of generalized seizure. By and large, kids who have a febrile seizure, it's going to be a diffuse shaking, upper and lower, left and right look about the same. With your partial seizures, you can have your no change in cognition, but then most of them will be a complex partial seizure where you have some level of change in cognition, meaning that the kid may not necessarily fully shake on both sides. They may just shake on one arm and be altered and stare off into space. Or your type of absence seizures where kids are just sort of staring off into space and then pop back into reality. They don't necessarily always have to shake. In terms of your management for seizures, ABCs, C-spine precautions if necessary, get your IV access. If the child has been seizing for more than 5 minutes or no response to your initial anti-epileptic, this is a time that you give whatever's available to you. Ativan, your midazolam, or diazepam, again, you can give it rectally. A lot of families with known seizure disorder will have their rectal diastat at home. That's another option to be given. I'm sorry? I was mostly an Ativan person, but I'm actually leaning a little bit more to midazolam because I find that from my experience, you're getting a little less respiratory depression with your midazolam, or like acute respiratory depression with your midazolam as opposed to the Ativan. Because, you give a kid a couple doses of Ativan, and next thing the kid is snowed, and it's a PCO2 of 100, and, you've got to intubate, and you're like, man, I just want to wait it out a little bit, but I don't want to give them reversal agent because I don't want them to seize again. So I'm leaning a little bit more to midazolam at this point. And then whatever available testing that you have en route or during transport, whether it be checking the sugar, checking the lights, and then eventually getting into the ER and checking a tox screen. If you've given a couple of doses and that still hasn't responded, that's when you start needing to talk about, talking to med control about starting some phosphatidone on arrival, or if you happen to carry that will be your next level drug. And these are the doses. Again, the diazepam can be as a rectal gel. And you can actually get intranasal midazolam. I've never actually done that. I've always given IV midazolam, but that is technically an option in terms of the pharmacokinetics for it. So you pack up the kid, you realize it's a febrile seizure, you start moving, and then so you're getting some apnea and some airway obstruction. So technically this does not fit the definition of apnea because kids are given up to, at least infants are given up to 20 seconds to not breathe and it technically be okay. But for the purposes of learning, we're just going to go ahead and call it apnea. In terms of, so what do you do in terms of these complications that you might get for your respiratory depression, especially infants, little chubby ones, because they have big heads and all babies have big heads and little bodies. Laying them flat on a surface is going to cause their chin to go down, and that's going to help to occlude their airway. So really what you want to do is get a roll behind the shoulders, not necessarily behind the neck, but more so behind the shoulders, so you can get that head to flop back a little bit and open the airway a little bit better. Sometimes the jaw thrust is also necessary. One thing that you can always do, again, in the absence of trauma, or a non-fractured patient, patient with a coagulopathy, is a nasal trumpet. I love these, especially in your post-ictal patients, because when often they're breathing well enough, and you insert one in, let it sit there, and as the child is waking up and becoming much more fussy, you're like, okay, the kid is more awake and alert, and you can take that nasal trumpet out at that time. Oral airways should only be used in patients without a gag reflex, but that is a potential adjunct if you find that you're going to need to intubate the child. So back to our questions. One mnemonic that you can use to help you remember altered level of consciousness in children is vitamins. Which of the following do not contribute to maintaining a normal level of consciousness? They all do. They're all relatively important. Which is not helpful in identifying causes of altered mental status? This is a trick question. I was hoping that people would pick time of day, but actually time of day is actually relatively important because your diabetic kids, if they've given themselves too much insulin at night, sometimes can be very hypoglycemic in the morning. I had when I was a resident, I'd gone to a diabetes camp, and I'm not diabetic, but every night, right around 3 or 4 o'clock, everybody would get woken up just to make sure their sugar wasn't too low, myself included, even though I wasn't diabetic. So time of day, so your blood sugar may be a little bit low at 3 in the morning if you're diabetic, if you gave yourself a little too much insulin the night before. Oh, so it should say none of the above. Yes, so they all do contribute. Thank you. Categories of seizures are generalized and partial. Complications of your benzodiazepines, respiratory depression and apnea. In terms of some take-home points for altered mental status, AEIOU tips and vitamins are good ways to remember causes of altered mental status. Febrile seizures are quite common in children. Your benzos are your first line of therapy, but may cause respiratory depression, and then you may need to employ some of your additional airway junks in your post-seizure patients. All right, next. Get called for a 4-year-old, excuse the picture, 4-year-old for an allergic reaction. Ooh. Pediatric assessment triangle for this patient. If you were to begin video, the patient would be fussy, not consolable, would be pretty anxious, having diffuse retraction, very increased work of breathing with a cap refill of about 3 seconds. So this little one was at a play date and was given a piece of a cookie by another kid's sibling who didn't know. This child had no medical problems, was a full-term child, shots up to date, no known drug allergies. Initial assessment, temp of 37.2, heart rate of 150, breathing about 35, blood pressure 80/40, 92% of room air. Was awake and cranky, a little bit anxious, some inspiratory stridor, diffuse retractions and wheezing with shortness of breath, with a cap refill of about 3 seconds, but was alert with no signs of trauma. So what's on your differential? Anaphylaxis, awesome. So is a skin reaction, hives, or urticaria a requirement for the diagnosis of anaphylaxis? Not to the end, not to the end. Don't shout out the answers. After giving IM epi, which of the following are appropriate interventions to consider when treating anaphylaxis? Elevating the feet, an epinephrine drip, normal saline boluses, none of the above, or all of the above. In terms of diagnosing anaphylaxis, you have to have several different findings, or there's 3 different criteria that you use to diagnose anaphylaxis. So skin and mucosal findings count as 1, and then you need at least one of the following, whether it be a respiratory issue or reduced blood pressure would be criterion 1 in terms of diagnosis of anaphylaxis. Criteria 2, if you have 2 of the following, so you could have hypotension and GI symptoms, and that technically be anaphylaxis in a patient with a likely allergen. or it could be a skin issue and hypotension, again, skin issue and GI symptoms as well. And then criteria 3, basically if the child is hypotensive after a known allergen for the patient, irrespective of skin findings. So in terms of your management, epi. So you can give it every 3 to 15 minutes. Then you want to support your airway and breathing. Intubation would be the least preferred option because if you have that much profound swelling in the airway, that's really a critical airway. It needs an anesthesiologist, a surgeon, or an ENT specialist because that kid may need an emergency cric and or trach. Albuterol nebs can help, especially with the wheezing and the respiratory component. You can get your IV or ioaxis en route. You can provide 20 per kilo of your fluids. Again, in the event that this is a child that is not responding or very minimally responsive to your epinephrine, they can go into distributive shock. Again, distributive shock is when that fluid has just essentially gone into the tissues and is not in the intravascular space. So you may need to pump them full of fluid to keep those veins and arteries distended. Vasopressor support may be needed in terms of an IV drip of epinephrine, but you also need to make sure you talk to medical control. So in terms of our diagnosis, do you need a skin reaction to be able to diagnose anaphylaxis? No. After giving IM epi, which of the following are important to consider? Actually, all of the above. So elevating the feet if you want to keep the venous return back to the more core of the body. Again, we just talked about an epinephrine drip because that may be needed in patients with distributive shock. And then fluids. You want to fill up the tank as much as possible. So some take-home points. Skin findings are not always required. IM epi, give it first, give it fast, give it at least 3 times, and then you may need to start an epi drip. Next case, you get routed to a call to a house. You get routed to a house for respiratory distress. And you find an 18-month-old female with trouble breathing, has had several days of coughing, runny nose, and low-grade fever. On arrival, you see this.
You sick, baby? Good. Mr. Larry, can you stay with me? Huh? Oh. Croupy. Oh, who got the croup? Baby. Oh, yeah. Oh.
So in terms of your pediatric assessment triangle, I'd say the kid is awake, alert. She's not particularly interactive with dad. She just looks like she's not really interested in what he has to say, but otherwise appropriate. Istakipnik is having supraclavicular retractions with an increased work of breathing, but at least from the video, we can sort of gather that the child is well perfused. Respiratory rate of 68. It's a little closer to 60 when you actually count it from the video, but we'll just say 68 for the purposes of learning. Heart rate is 170, is febrile. Blood pressure is 90/50, is 92% on room air. Kid is awake, alert, and calm. Patent airway with retractions as mentioned, but moving air well. Cardiovascular exam is fine. Kid's alert with no signs of trauma. So what's on your differential now? I heard croup. Did I hear anything else? Upper airway obstruction. What else? And what's your management plan? Racemic. Okay. Anything else? Maybe a little albuterol too? Okay. So I'm not going to tell you exactly what I think this is. We'll get to that in a second. So croup is an inflammation of the larynx and trachea. It's usually a viral infection. Often these kids have like 2 or 3 days of cough, cold, runny nose symptoms, plus or minus fever, and then all of a sudden they develop this like barking cough. They can also just be very hoarse, and they can also have stridor. Cases of respiratory distress and failure, respiratory failure are possible. My experience is those kids are the kids who present sooner with symptoms, meaning like they don't have the several days of URI symptoms. It's like that day they had trouble, they had URI symptoms, and then several hours later they developed the cough. So the sooner you develop that croupy cough, the more concern one has in terms of this being more of a serious episode. Bronchiolitis is another option. Again, it's a viral cause. Frequently RSV, but your run-of-the-mill adenoviruses can cause it as well. It starts as an upper airway infection, then goes to the lower airways. And basically what happens in the lower airways is all of the tissue in the lung just gets sloughed off, and it's just sitting in the lung, so there's a lot of fluid, which is why you often hear a lot of crackles in kids with bronchiolitis, because there's a lot of fluid in the lung. Then they develop their increased work of breathing and tachypnea. It's more common in the winter months, at least in the mid-Atlantic and Northeast. And affects children under 18 months of age. Usually it's their first winter that they'll get their worst episode. Sometimes, depending on what time of the year you're born, if you have 2 winters under your belt and you're 18 months old, you may get bronchiolitis again. And you can get it several times in a season. Asthma is another option to think about in terms of airway issues. It can be virally induced, it can be seasonal, it also can just be environmental issues that cause your asthma. You get a lot of swelling of the airway, you get a lot of increased muscle contraction. The smooth muscle of the lung actually contracts quite a bit, and you get a lot of mucus. Not enough mucus that you can suction from the upper airway, it's really mucus lower down in the airway. It can be year-round, but it, again, can have the seasonal variations. You formally have to be 6 years old to be diagnosed with asthma, because you have to be able to participate in the PFTs, or the pulmonary function tests. But there are plenty of infants and children who act like they have asthma, even from 6 or 8 months of age. So it's not uncommon for me to give a kid who I think maybe has bronchiolitis in a family who mom has asthma, dad has asthma, the sibling had asthma, or such and such wheezes, that they get treated like an asthmatic. So in terms of management of croup, you want to keep the kid calm, humidified oxygen, if possible. Sort of one of the classic teachings in pediatrics with respect to croup is that sometimes parents will say, oh, I heard this nasty cough at home. I bundled the kid up, brought him outside, brought him to the ER, and now the cough is gone. That cool mist really helps shrink down the tissues of the upper airway. So another option is, if it's possible, if you have cool mist, can also be helpful to decrease some of that upper airway swelling and some of that stridor. And then racemic epi is another good option as well. With your bronchiolitis patients, suction, suction, suction. These are the kids that you're going to have so much like snot and booger that it's going to be difficult to assess the airway and what their actual breathing sounds are. So as much as you can, without making the child too angry, you want to suction, 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 provide oxygen. Any of your airway maneuvers to help open the airway, whether it be the roll under the back, a little bit of a jaw thrust if the child will allow, or let the mom allow, and then albuterol and racemic. Some people, I think, depending on the provider, some people start with racemic and some people start with albuterol, and then they switch. My preference is to do racemic unless there's a history of albuterol. And then if the racemic doesn't work, then I'll give them a dose of albuterol. If that doesn't work, then neither is going to work, and it doesn't matter. We just have to support you through it. You may just need to get admitted to the hospital for some positive pressure, non-invasive positive pressure ventilation and oxygenation. And then asthma, again, your albuterol is your first-line treatment. So you pick up this kid. It takes a really long time to get to where you need to go. And the kid starts to look like this. What are your thoughts now? Could be asthma. What else? Whatever it is, the airway needs to be managed right now. Yes, I'm getting nervous looking at this kid, yes. So if you repeat your assessment, temp is 38.5. For the sake of education, we'll just say the respiratory rate is 10, but clearly the video wasn't 10. Blood pressure is only 60, is 85% on room air, heart rate is 100. We'll just assume that this kid in the video is a little sleepy, less interactive, which he was. Airway was patent, was diffusely retracting. I didn't put head bombing in there, but that was definitely in the video. Cap refill was okay at 3 seconds, was really only responsive to pain. So where are we now? Hold on. I'm sorry? Ventilating. Interesting. So what is an appropriate ET tube? Oh, sorry, what is an inappropriate size of ET tube for a 2-year-old? Oral cuffed, oral uncuffed. Oh man. This should say appropriate. This should say what is an appropriate size? An appropriate, yes, an appropriate for a 2-year-old. I left my teaching days behind, so please excuse me. We'll come back. So you decide to intubate with midazolam and rock. What are some potential complications of this combination in children under 5? And really it's more focusing on what is a potential complication in intubation in a child under 5. Which of the following is true in children? Cardiovascular failure follows respiratory failure, or is it the other way around? So respiratory distress, we've been talking about wheezing, tachypnea, stridor, et cetera, mild hypoxia, but the kid still maintains perfusion, but can progress to respiratory failure. In terms of your symptoms of respiratory distress to failure, you can get a little wheezing with distress, you can get some stridor with distress, maybe just a touch of pallor, but nothing impressive, and maybe a little bit of nasal flaring and some tachypnea in terms of respiratory distress. Once you start getting into your respiratory rate above 60, and developing any of these other things, you're really getting yourself close to respiratory failure at this point. There are some kids who are just happy and tachypnic. Some of your run-of-the-mill average bronchiolitis kids can be breathing 60 to 70 times a minute and be still sipping on juice and absolutely fine, but they don't have any of these other sort of worrisome findings. When you start adding tachypnea and other things, that kid is really working hard to breathe. And what you don't want to do is you don't want to get to the point where you're here in this red box. Cyanosis, not breathing very fast, not moving air, and their lungs are so tight that they're not even wheezing at all. Again, respiratory failure, you have poor perfusion, the decreased breathing. So if they were breathing well and they're not breathing so much, they're telling you that they're on their way to apnea. Altered mental status, always worrisome, because at this point they're starting to not to protect their airway. So indications for intubation would be ineffective ventilation or apnea or profound hypoxia, cardiovascular arrest, if you want to take control of the airway to protect for aspiration, or in patients with possible increased ICP, you may want to be a little bit more aggressive in managing the airway to hyperventilate to get some of that CO2 down to bring some of the swelling down as an adjunct to other things. So there's some differences between the pediatric and the adult airway. So kids, their trachea is much more narrow. It's narrowest at the cricords. So when you get kids who inhale your various objects, it often gets stuck sort of right up in the airway. So that video that we saw earlier where the kid was just sort of sitting and retracting and pulling here, foreign body is definitely a reasonable thought. And if it's going to get stuck in the airway, it's going to get stuck up here. The epiglottis is larger in children. The airway is more anterior and superior as compared to adults. I'm not sure if any of you have intubated children at all, but intubation of children really requires you to pull up and up to the corner of the room because you really want to get that airway down. Where adults, in my experience, I've not done that many adults, but big people, you just sort of stick it in and there's the airway, like, wow, there it is right there. Who'd have thought it? Kids, you have to work for your intubation a little bit harder. And then the tongue is larger in kids with respect to the proportion in the mouth. So any little swelling, inflammation, irritation can really start to occlude what's already a small area. So cuff tubes are actually preferred in children. There was a lot of teaching earlier that the cuff tubes were bad, but they've changed the way that they make the cuff tubes now. So I routinely use cuff tubes. I can get, under a 3.0 cuffed tube, but you sort of use what you have. But a cuffed tube is acceptable in children. To calculate your cuff tube is 4 plus the age over 4 years, and then you go about a half size down or full size down for a cuffed tube. In terms of vagal stimulation, kids are very responsive to the direct laryngoscopy during intubation, and so very often these kids will become bradycardic for various reasons. One is the vagal stimulation, and then 2, if there's some vagal stimulation and the kid is a little bit dry, you can sort of bet your money on a little bit of bradycardia. Maybe not necessarily to the point where you need to do chest compressions, but that's something for which you need to be prepared. And then a curved blade or a straight blade, it's your preference, whichever one you want. Some people, my teaching is that whichever one you get your first successful intubation with is the one you stick with, and that's sort of been my experience. Whichever one I liked the first time I got it is the one I'm sticking with. So it's, again, this should say what's an appropriate ET tube. So both of these are appropriate for a 2-year-old. So either a cuffed or an uncuffed tube. So in terms of complications, bradycardia again is a complication. Hypotension is also possible, but my experience is that you're probably going to see bradycardia first before you see hypotension. And you manage the airway, you can save the heart, but if you don't manage the airway, all is lost. Some take-home points, respiratory distress can lead to failure if not managed appropriately. You can use cuff tubes, and then atropine should be strongly considered for kids under 2, especially kids who are getting succinylcholine and or multiple doses of succinylcholine. You really want to consider atropine. Some places routinely use atropine for those under 5. Some places just use it for under 2. Some use it just for multiple doses of sux under the age of 5. So it just sort of depends on what your jurisdiction indicates. That's about it. Any questions?